Hi, everyone. Thank you for joining us today. My name is Megan Brown. My pronouns are she, her. I am the secretary on the Harm Reduction Nurses Association. Today, we are here with Marlene Haines on the topic of stimulant safe supply. I'm just going to get started first with a land acknowledgement before we start. So the HRNA would like to acknowledge that the land we work and play on is the ancestral and unceded territory of the Indigenous peoples of Turtle Island. We would, of course, also like to acknowledge the intersectional impacts of colonization, racism, and white supremacy embedded in colonial systems, which exacerbates substance use harms. While acknowledging territory is very welcome, it is only a small part of cultivating strong relationships with Indigenous peoples. This should take place within the larger context of genuine and ongoing work to forge real understanding and to challenge ongoing colonialism, racism, and white supremacy in health and harm reduction settings. We strive to collaborate with and respect all of the Indigenous peoples of Turtle Island in our work. We also like to acknowledge the tremendous work and sacrifice of people with lived and living experience of criminalized substance use and poverty, who have assumed often the largest risk in innovating overdose and harm reduction response and keeping their communities safe. Without their generosity, organizations like the Harm Reduction Nurses Association would simply not exist. Okay, thank you very much again, everyone, for joining. Today we have Marlene Haines with us, as I said previously. Marlene Haines is an RN and PhD candidate in the School of Nursing at the University of Ottawa. Her program of research focuses on the drug poisoning crisis, harm reduction, and drug policy. She is also a registered nurse with clinical experience in safer supply programs, injectable opioid agonist therapy, and works with individuals who use substances as well as those who are homeless or unstably housed. So we'll pass it over to Marlene shortly. It's me and Corey here today from the HRNA board. Corey is here to help moderate the chat. Corey, do you want to say hi?
Oh, I'm just really happy everyone's here. Looking forward to this presentation. Thank you, Marlene, for being here. I'm Corey. I use he, him pronouns, and I'm joining you today from the unceded stolen territory of the Powhatan tribe in what is colonially known as Duncan. And yeah, I'm going to be supporting on the back end. So just making sure people have questions answered in the chat. Yeah, looking forward to this. Thanks so much, everyone, for being here.
Okay, Marlene, and I'll pass it over to you if you would like to start sharing your screen.
Great. Hopefully everyone can see that okay. Okay. Thank you so much for the introduction. I feel like that kind of summarizes me, and I'm really happy to be here with kind of the Harm Reduction Nurses Association. Lots of fun to be presenting to nurses and to chat kind of about what we're doing here in Ottawa. So we're going to be speaking specifically about safer stimulant supply programs today. And the team that I work with here has been doing the kind of evaluations of the safer supply programs in general in Ottawa for some time now. We're into the 4th evaluation that will be released probably sometime in the summer. And interestingly, that will also focus on safer stimulants, but it will be a kind of a qualitative portion, kind of speaking to people about their experiences, whereas today, we'll get to it in a minute, but we're looking more at kind of quantitative results, like, so we pulled things from chart reviews and stuff like that. So just some quick disclosures. The funding for research comes from Health Canada's SUAP program, similar to lots of the Safer Supply pilot programs that you all probably know across Canada. But what we're talking about here today doesn't necessarily represent their views. This presentation really reflects my own clinical and research viewpoints, not necessarily those of all the organizations that offer different harm reduction and safer supply programs. And I have no financial or no financial relationships to disclose and no significant conflicts of interest to disclose. So for today's presentation, I'm going to just start with some background information about the drug poisoning crisis, with an emphasis on stimulants. I'm also going to provide some background about the Ottawa programs here in particular, as well as kind of just a brief introduction of kind of what Safer Supply is for those of you who may not be as familiar. Then we'll look at kind of an overview of Ottawa's Safer Stimulant program. I thought that looking at kind of the clinical aspects of the program could be really interesting for this group to kind of really understand how these programs run and how they work. And then I'll be presenting on kind of the chart reviews that were completed, like I mentioned earlier. So we kind of looked at outcomes related to things that we were able to pull from client charts. I'm going to touch briefly on some important topics regarding the future of Safe Supply, and then we can wrap up and do a Q&A. I'm really hopeful we have a decent chunk of time to do that, because I always like that part and being able to kind of really get at what everyone wants to hear. So with that, just to kind of start off with some context. So we know that the drug poisoning crisis in Canada is getting worse, and that people who use drugs are continuing to die at unprecedented rates. And so most recently, Health Canada reported more than 40,000 people since January 2016 have died as a result of the drug poisoning crisis. And so in the first half of 2023, this was equal to about 22 deaths each day. We know that fentanyl is a driver of this crisis, with 84% of opioids toxicity deaths specifically involving fentanyl in 2023. And we also know that drug checking can be hard to come by for people who use drugs in the community. And this is really important that we're able to get access to kind of more drug checking so people can understand how the drug supply is changing. You'll see I'm going to present some results from a group in Toronto who's doing a lot of the testing in Ontario. Yeah, so we can chat about that then. And this is kind of all within the context, of course, of people who use drugs being a really marginalized and stigmatized group of people that are criminalized for their unregulated drug use, and kind of this just further compounds inequities. And so we can just continue to jump right in. So looking specifically at drug use trends, we know that recently, like in the past few years, polysubstance use, often involving a combination of opioids and stimulants, has become increasingly common. Health Canada did report that more than half of opioid toxicity deaths also involved a stimulant drug, and 81% of stimulant toxicity deaths also involved an opiate drug. So clearly, yeah, polysubstance use is becoming more common. And I think it also emphasizes the fact that the drug supply is so toxic and is so unpredictable. So amplifying this concern specifically for people who use stimulants, there exists very few evidence-based resources for them to address their stimulant use. So what I mean by that is, for example, there's not necessarily a gold standard medication for treating a stimulant use disorder, as there is, for example, with an opiate use disorder. Things like OAT, like methadone, Suboxone, exist and have been around for a long time for opiate use disorder. But for people who use stimulants, there's not a ton out there. Most of the interventions focus on things that are focused on psychosocial things like counseling and outpatient therapy approaches, which can often be rooted in abstinence. And while this may work for some people, for individuals who might not be seeking treatment or maybe are just looking for increased safety, services like a Safer Stimulant program can be useful, but at this time are really scarce and can be very difficult to access. So like I had mentioned, the Toronto drug supply, I think this kind of just helps to highlight how toxic things are. So I pulled this from drug samples completed in 2023 when people said that the expected drug that they thought they were using or had purchased or had received was unregulated fentanyl. And so this is really why we call it a toxic drug supply. People are not aware of the drugs that they're using for the most part. I've had clients or research participants refer to it as Russian roulette, and that you just don't know what you're getting every time. And it can be a really scary thing. As you all know, we're seeing influx of things like benzos, but there's also lots of fear mongering in the media around fentanyl. And I would say we've come to a place where at this time, people are typically looking for fentanyl if they're looking for unregulated opiates. Heroin is no longer here, at least in kind of the major cities, and fentanyl is the more common drug that people are finding. So I just thought that this was important to look at. So before we dive into safer stimulants in particular, just to cover kind of what is safer supply in general, I really like the Canadian Association of People Who Use Drugs put out a really fantastic safer supply concept document a few years ago. The top quote there that you see is from it. So they just kind of summarize it as a legal and regulated supply of drugs with mind-body altering properties that traditionally have been accessible only through the illicit or the unregulated drug market. CPSO, you can see, put out a statement under there. So the College of Physicians and Surgeons of Ontario specifically kind of just put out a statement about this being an emerging area of clinical practice. And I would say overall, safer supply is a response to the drug poisoning crisis. It's based in a harm reduction approach and aims to decrease harms related to the toxic unregulated drug supply. I do want to note, and I think it's important to note, that safe supply is a really broad term that includes offering someone an alternative, safer version of a substance. Accessing safe supply can be things like a medicalized model, like I'm speaking about today. It can involve, nurse practitioners and physicians and nurses and all those sorts of people. But things like peer-led buyers clubs for purchasing, testing, distributing substances, that is also safer supply. I think this is really important because when people think about safe supply, they often think about the medicalized model, those pilot programs that have SUAP funding, but in reality, like all good harm reduction programs, safe supply was originally conceptualized by people who use drugs themselves outside of the healthcare system. And so I think it's important to acknowledge that before we kind of dive into the more specifics. And so this slide I'd just like to show because, it really does highlight that, yes, today we're focusing on stimulants. And typically when you hear safe supply, a lot of people think opiates because that's what's most commonly available right now. But safe supply is certainly not synonymous with opioids or stimulants. It can be any sort of substance. If you've been to a bar to drink with friends or gone to LCBO to pick up alcohol, you can consider all of those things safer supply. You're accessing a regulated supply of drugs. So specifically here in Ottawa, we have a really unique and I think fantastic setup with kind of the program bringing together 7 different organizations to provide really comprehensive care and services to people who use drugs. So the top 3 circles that you see, Recovery Care, Ottawa Inner-City Health, and Somerset West, are all the prescribing sites. Then they offer for safer supply, and some of them also offer things like primary care and supervised consumption services to participants as well. Places like Sandy Hill, you can see on the left there, provide wraparound care such as intensive case management, peer connections, things like that. Respect RX, you can see just kind of at the bottom left. They are not a pharmacy that anyone has to use. People could pick the pharmacy they'd like, but a lot of the clients really like the pharmacy because they are a kind of group of people who really understand safe supply, are really committed to it, and are really committed to a harm reduction approach. Ottawa Public Health is also on there, and they help with things like the creation of policies and procedures that are available on the Ottawa, or some of them are available on the Safer Supply Ottawa website. They also help to provide data on substance use and what's happening. And then Options Bytown provides support through on-site housing for people who are homeless or unstably housed. And so there are differences in care day to day, even within the programs in Ottawa, just given the different organizations. And I would say across Canada, there's certainly differences, but I'd say the philosophy of care kind of at its core is very similar across all places. I won't get into like every single point. I'm happy to share my slides if anybody wants to go and read everything. They're also available in our reports. But things like developing objectives and goals for the program based on what the participants, what's important to them and what they need. Looking to provide a trauma-informed approach to care. Always committed to evolving and changing based on the needs, based on what's going on with the toxic unregulated drug supply. Providing as low barrier access as possible to care as possible, things like that. And so sometimes people ask as well why someone might want to start a program. There are many reasons why people might be seeking to be safer with their substance use. They might be trying to mitigate harms and risks associated with unregulated drug use. There are lots of different reasons, but I think overall it's important to note that the goals are created and implemented by the participant and their care team. So there's no one specific goal necessarily that people have to have. They can have lots of different goals. And then, so in Ottawa, we have kind of three, I guess you could say, well, three different programs within the programs that exist. So three different, I guess, routes people could take based on what works best for them. So Safer Opiate Supply, as I said, is the most common in Ottawa, but I think also across the country. So people are often prescribed hydromorphone tablets and long-acting opioids to help with managing kind of cravings and withdrawals related to the unregulated opiate supply. And then today we're going to be focusing on safer stimulant supply. So looking at providing a replacement for things like crystal methamphetamines, cocaine, crack cocaine, things like that. And so people are commonly prescribed kind of methylphenidate to help with that, although there are lots of different medications that, again, we'll get into. And people can also be on a combination of both if that's needed for them and if that works for them. So specifically with regards to safer stimulant supply programs, Ottawa in particular is one of the few places in Canada that currently has a safer stimulant supply program similar to safer opiate supply. It's based in harm reduction to try to reduce harms related to the toxic unregulated stimulant supply. People are often prescribed short or long-acting prescription stimulant medication. Most commonly, it's methylphenidate immediate release tablets that people can choose to take. They can take it orally, they can cook it and inject it, they can take it whatever way works for them. And then a long-acting methylphenidate capsule, usually, which they take as a witness dose each day with the pharmacy. And yeah, so people kind of have options within that, and doses are titrated to meet their needs. So if we start at the beginning with program intake, during the program intake process for a safer stimulant program, participants and their care team complete a really detailed clinical intake form to assess if they're an appropriate candidate for the program. They do things like review and sign a program agreement with their prescriber. They have kind of the medications explained to them, things like, you know, how to use the medication, the dose, the potential side effects, adverse reactions, baseline vitals, ECG and blood work are always completed. And these are just a couple of things, of course. I didn't go into the entirety of the policy in this presentation because that would just take too long, but kind of these are the highlights. And then each participant kind of formulates their personalized program goals with their care team. So as I said before, these are just based on what people are looking to do, but some really common ones are often people are looking to decrease or discontinue their unregulated stimulant use or decrease their risk of drug-induced psychosis. They may hope to decrease their risk of cardiovascular morbidity, decrease their risk of infectious disease transmission, or decrease their participation in criminalized behaviors, or improve their mental and physical health. So those are all really commonly kind of common goals stated by clients and their care teams. Perfect. So similar to goals, prescriptions are decided on and based on individual participant factors. So on this slide, I've kind of put some examples as to what long and short acting medication prescriptions may be started at and titrated to. I just find sometimes when you come to presentations, whether it's about safe supply or about anything, it can be useful to actually see like what does it really look like in practice. And so this is a great example of that. You can see on the left the long-acting medication. I had mentioned the long-acting methylphenidate, but you can see there's other things that can be used, that are commonly used as well. And then on the right, there's the short-acting methylphenidate tablets. They're usually the 10 milligram tablets. You can see kind of the initial dose, 20 to 40 milligrams usually, and then they get titrated from there. And there are maximum doses. So for example, the site in Ottawa specifically, between the long and the short acting or the immediate release, the maximum dose per day of methylphenidate is 200 milligrams per day. And so that's specific to how the physicians and nurse practitioners do things here. And again, this is all in the report that I will share, and I will give all of you these slides because I know it's a lot of information all at once. So as well, I wanted to give an overview of kind of really clearly what the intake criteria looks beyond kind of those things that I touched on before. So typically inclusion criteria, it includes people who are diagnosed with a stimulant use disorder, and typically usually attempts have been made in the past by people who, they might have tried contingency-based management, or they have social or medical barriers to accessing traditional management. And so safe supply, based on kind of the assessment of the provider and the patient, it makes more sense for them to do safe supply right now. Exclusion criteria do not meet the criteria for stimulant use disorder, which makes sense. If somebody can't consent for a kind of a harm reduction based approach, or just kind of can't consent to the program in general, if people can't attend regular appointments, then these are things that would be considered likely exclusion criteria if a plan couldn't be put into place to work around them, which often can happen. Things like that are absolute contraindications. So if people have a history of cardiac issues, just because stimulants can exacerbate these issues, a history of thyroid toxosis, or a neuroendocrine kind of types of neuroendocrine tumors can also be an absolute contraindication. Different types of like antidepressants being used, personal and family history of Tourette syndrome, things like that, or sensitivity to the medication, of course, being used. All of these different things can kind of are reviewed with the patient, and detailed assessments are done just to make sure that it will be safe moving forward to prescribe this person stimulant medication. And then finally, there are relative contraindications, meaning that these things would be kind of, again, they would hopefully, like, they would go through these different things on the intake, but hopefully they could put into plan kind of they could put into place a plan that would address these. And hopefully if the person, if the person really needs a safer supply program, they can kind of work on these contraindications to make sure that they are able to access a program safely. So lots of different things are considered basically by the team. Really detailed assessments are completed. Really detailed medical chart reviews are completed, and kind of things are also assessed, of course, on an ongoing basis. People do regular check-ins with their team to make sure that they're doing okay, and to continue to assess these criteria and to see how people are doing, how the program is working, how it can be adjusted for them. So given the lack of kind of research and evaluation available regarding safer stimulant programs, we wanted to do some focused medical chart reviews of participants within this program. So the data that we extracted was from program intake and check-in forms that were collected on an ongoing basis by the clinical teams doing safer stimulant supply. Data collection occurred mid-February 2023, so this is just over a year ago that we did the data collection. And I think it's important to note when you're looking at these numbers that it's only the people who were on the program at the particular time of data collection were included, because that's all we had access to at that time. And so in total, in the end, there were 28 people who were included in this evaluation. Like I said, the Safer Opiate Supply Program is much larger here. I want to say off the top of my head, there's maybe 300-400 people on the Safer Opiate Supply Program, or certainly between the opiate and the combination. The safer stimulant tends to be a smaller, but still very important program. And so data that you'll see today is just reported using descriptive statistics. So we didn't run any sort of statistical analysis at that time. So as I mentioned, there was 28 participants in total on the program. There was a median age of 37, and a median time on program was 9.5 months, meaning that of all the people that we looked at, the group of 28, they had been on the program for a median of 9.5 months at the time of mid-February 2023. So there were 22 men and 6 women on the program. I do want to point out that self-reported gender of women and men included both cis and trans individuals. This was completed specifically because the number of individuals who are trans within these programs is very small. And so we did this to protect privacy and confidentiality of these people. So less than high school was the most common believe reported highest level of education for people, and most participants were on ODSP, which is Ontario Disability Support Program here in Ontario, followed by OW or Ontario Works, and then a couple of people reported other forms of income. So during the intake assessments, or during the intake, things like behavioral assessments, including risk factors, are completed with all participants and their care teams. So I won't read off all of this, but highlighting a couple of things. The majority, so 71% of participants reported experiencing some form of abuse, whether it be physical, sexual, emotional, mental, over their lifespan. Nearly 2/3 of participants reported experiencing a drug overdose, and half of participants had used a supervised consumption site, and half reported having shared drug use equipment with peers. The median age of when people started to use drugs in general, so this could be any drug, was 14. And the median age when participants reported that they started injecting drugs was 21. So at program intake and at check-ins, they do ask a lot of different questions. As I said, some of them are around housing status and primary care. So at program intake, on the left there, you can see that 39% of participants reported that they were staying in a shelter and 61% said they were housed. At the mid-February check-in, 29% said that they were still living in a shelter, while 71% reported being housed. So of course, the number of people being housed did slightly increase, which is great. And I think it's important to note too that no participants went from being housed to living in a shelter. Instead, the change that you see is only related to the 3 participants having left the shelter environment after obtaining housing, which for anyone who is involved in shelters or housing, you know that it can be depending on where you live, but I think it's just becoming a more common thing that getting housing in general is very challenging for anyone. And so kind of when you think about that people were on a program for a median of 9.5 months, seeing 3 people shift from being kind of in a shelter to being housed, it's just a good thing. We can't say exactly what it's related to, but I think it's an overall just a really nice thing to note. And then on the right, you have nearly a third of participants. Oh, sorry, still on the left, we're still at housing status. So nearly 1/3 of participants said that they had met with a housing worker associated with Safer Supply during their time on the stimulant program. This I think is important because in Ottawa, I told you about the 7 different programs, and I think it really does highlight or one of the strengths of the program here is how much wraparound care is associated with the programs. Primary care, housing support, all the counseling, the peers, all of these different things are built into the programs. And so I think that it is an important thing to note that doing Safer Supply and prescribing the medication is very important, but all of those wraparound care services are really important too. And then on the right, now we will move to the right to primary care access. You can see that the majority, so 71% of participants reported having no access to primary care when they first did their stimulant program intake. And at follow-up, nearly 90% of participants reported accessing primary care services since starting their program. So this is a massive change. Many of the participants, 75% of them, reported using the in-house wraparound primary care services offered by their program. So this is really fantastic. We went from the majority of people not having primary care to the majority of them having it and saying that, yeah, I'm accessing it within my program. It's really easy. And we've spoken to people and we know that anecdotally people find it, really useful and quite easy when they can just go see their doctor or nurse practitioner about Safe Supply and then go get something taken care of for their primary care and then head out for the day. I also wanted to note that there were 10 participants who were prescribed, so 36%, who were being prescribed medication unrelated to their substance use, so something for their mental health or infectious disease, along with their Safer Stimulant Supply medication. I just thought this was interesting because it does help to kind of underscore again the importance of having that wraparound care, because there were a decent chunk of people who were their Safer Supply prescriber was helping with other parts of their healthcare as well, whether that be kind of mental health or infectious disease. It was an interesting thing to note from the chart reviews. So outside of the safer stimulant programs, most participants were kind of accepted and offered to engage with a Hep C program. So anyone who starts a safer stimulant program is offered that to see if they'd like to kind of engage, even if it's, just to chat with a nurse to talk about risk factors or talk about safety. So among the group who did engage, there was 19 people who did engage. 17 of them said, after chatting with the nurse, said, yeah, I'll complete hepatitis C testing. Sure, that's great. And then of the people who completed testing, 8 people were Hep C negative, 6 were Hep C positive, and 3 had results pending at the time of chart reviews. And then 2 of the participants that tested positive opted immediately to start Hep C treatment right away, concurrently with their Safer Stimulant Supply medication. So that was really great as well, and really interesting to note. So as for drug use changes, before starting the program, participants reported at program intake of using a median of 10 points or 1 gram of cocaine per day at their most recent check-in. Since starting the program, participants reported using a median of 0 points of cocaine per day. If you look at crystal meth, at program intake, participants reported using a median of 1.5 points of crystal meth a day. And since being on the program at their most recent check-in, they reported using a median of 0 points of crystal meth per day. I just want to note that, so we use median because the data is not normally distributed. And because it's a more conservative estimate, when you have a small sample size that's not perfectly normally distributed. We didn't want to use mean or anything because that would be more likely affected by outliers and wouldn't be representative of the group. Yeah, so you can see really drastic changes in what people are reporting as their drug use, which is exciting. And then before we get into kind of the future of Safe Supply, this is the last slide about the program outcomes. So over the course of safer stimulant programs, participant stimulant medication prescriptions are titrated, as we chatted briefly about in the beginning, to address things like ongoing unregulated stimulant use, as well as to address ongoing cravings and withdrawal symptoms related to stimulant use. And so an overview of prescriptions is provided on this slide. And so it describes how prescriptions of the participants changed from their initial intake, which is on the left, to their current prescription so that mid-February 2023 check-in on the right. And this is also reported as median daily doses for the same reasons as the last slide. And so I think it should be, I think it's just interesting to see that there are, although methylphenidate long-acting is the most commonly used, there are lots of different options. This is all based on kind of, again, the intake that's done, what's best for the client, different things like that that are assessed over time. But then also, things change. Somebody might try a medication, it may not work very well for them. They try something out. That's very common with, as you know, any sort of medication that's prescribed, that, you try a whole bunch of things until you find the one that works. I do want to note that the vast majority of participants were only prescribed 1 long-acting stimulant medication. So there's a whole list of them here, but most people among that list were only prescribed 1, along with their short-acting tablets that you can see in the bottom there. So for the future of Safe Supply, looking ahead, what needs to happen? So more programs. There needs to be, more programs and increased program access. So SUAP funded programs are wonderful, but they aren't enough. And most of them are constantly at or past capacity. I think we're all hopeful to see more programs open. So anyone living in any community can have the choice of being assessed for a safer supply program if it's appropriate for them. And that would be a great thing. Also, given the limited number of safe supply specific providers that are doing that right now, and the fact that programs are full, there are noted frustrations from the participants about the lack of portability. We found that in our first kind of research evaluation we did, that it's very limited to where you can live and what you can do. You can't just pick up and move, which is unfortunate, because if you're someone who maybe is here in Ottawa, and you get on Safe Supply and you stabilize a lot, and then you want to go back, maybe you want to go back to Manitoba because you want to be with your family there, but the place that you're looking at going to, there's 0 Safe Supply prescribers. that can be a really distressing thing for people, right? Especially people who are trying to meet their goals, who are trying to do different things in their life. So I think that more programs overall are really important. We need different models of care. You know, we need all types to meet the needs of different people. You know, there were the 3 different prescribing sites in Ottawa. One of them is within a consumption site and shelter, you know, with nursing staff more readily available if people need increased levels of support. There's also places that are available kind of in more of a traditional substance use clinic. There's a community health center one, or a community health center based safer supply program here. All of these different types of models of care are really important. We also need things like hospitals and jails and prison to kind of, we need to be looking at how we can get safe supply there, because at least here in Ottawa, you know, people are not able to get their medications if they are, you know, incarcerated, or sometimes they're not able to get it if they're hospitalized. And this can be, you know, really distressing, and this can be, you know, life altering to not get the medications that you need. Expanded drug options. People are asking for things like injectable fentanyl, and I think it makes sense. When the unregulated drug supply is fentanyl, people are looking to match that with a regulated supply of injectable fentanyl. You know, people are asking, some people are still asking for injectable heroin, although it's not really a thing within the unregulated drug market as much anymore. It certainly was for a very long time, and people are wanting that. People are also asking for things like, you know, the dose caps that are kind of used right now. People are saying they're not high enough. People want things like safer benzos, because unfortunately it's gone to a point where benzos have flooded the drug market. And so this is something that we need to address. And so overall, I'd say the feeling is that people are asking to have the drug that they're prescribed match the drug that they're using, to kind of really have the most impact and be able to address kind of what they need. We also need more providers. I did touch on this in more programs, but I think, you know, integrating safer supply into primary care in general is really important, and it's something that we need to be pushing towards. Safe supply shouldn't be, you know, one-off clinics here and there. It should be part of a comprehensive, you know, plan of care that can be offered to people as appropriate. I did want to also briefly note the importance of decriminalization. So this is a quote from RNAO about, you know, that substance use is a matter of public and personal health, and that, yeah, the criminalization of substance use, it really does take focus and resources away from the care of people who use drugs. You know, and although having things like, you know, drugs regulated, like having stimulants or having opiates regulated in similar ways to other substances like alcohol and cannabis would be wonderful, and regulation is absolutely something that I think almost everyone in safe supply would be pushing towards. I think decriminalizing now is so important. You know, people who use drugs are constantly faced with being labeled as someone who is sick within the healthcare system, but they're also a criminal within the law, the law enforcement system. And you know, managing these labels is really exhausting, and it's unfair to them, and it just makes for this really tricky landscape of getting care in a way that makes sense. And on that note, you know, we can see the blowback of criminalization of substance use. Something that happened, you know, a couple months ago with DOLF. Likely a lot of you already know about this, but for those who may not, DOLF is a compassion club led by people who use drugs, where drugs are brought in bulk, tested for purity and contaminants, and then distributed at a reasonable cost to kind of a group of people who use drugs. And they, for a long time, were able to do really fabulous work, and were saving lives. And just like safe supply, their primary outcomes are to reduce the number of fatal and non-fatal overdose events, improve quality of life, things like that. Their initial research showed that their program was seeing really great success, and they were working within a research institute to perform regular evaluations. And, you know, unfortunately, arrests were made in the fall of the founders, and kind of things were shut down at that time, which is really unfortunate. But I do think it's important to talk about. Yeah. If anyone is interested, I wanted to include this slide as this is the website where you can find all of our evaluation reports to date. The top right, the kind of beigey Safer Supply Ottawa Evaluation Spring 2023 report, that is where you can find most of this information that I've presented on today, or pretty much all of it. And then the other two reports are out as well. Our newest one is in the front there that just came out, where we covered program restarts, so people who were kind of on and off the program. We also got into talking about diversion with people, and I will be back for another webinar at some point this year to chat with you all about diversion and kind of the results of that, which I think will be really interesting. And as I mentioned at the beginning, we're doing more safer stimulant supply research right now, doing interviews and surveys with participants, hearing from them. And as soon as that's available, I will absolutely share it with the HRNA and all of you. And that, I think, is it. That's my contact information. I love hearing from people. Please reach out. And otherwise, just references for anyone who might be interested. And that is it. Thank you for listening.